Welcome, and thank you for joining this webinar, which we hope that you will find useful and informative. My name is Professor Dame Parveen Kumar, and I have the pleasure of chairing the Board of Science for the BMA. I'd also like to introduce you to Dr. J.S. Bhamra, who is the Vice Chair of the Board and will be co-chairing this meeting. This is the first webinar in a series of 3 virtual events that the Board is hosting. Today is on knife crime. We'll be having another one on climate change, and subsequently one on a look back on the COVID pandemic and crisis that we're going through at the moment. So before we start, I'd just like to explain to you your role in this seminar. You can all submit your questions on a live Q&A box, which is on the right-hand side of your screen. If you like a question which you would like asked and it's already been asked, please put a thumbs up sign, as the more popular questions will be more likely to be asked. We will, of course, also be asking some of the questions you've already submitted when you registered, so we hope to cover as many as we can. So really back to knife crime, and this is really an extremely important topic, particularly in the current climate. The number of knife crimes in England and Wales rose to a new record last year, and there were over 46,000 offences, a rise of about 6% from the previous year. Knife crime is now the biggest concern amongst young people, according to a worldwide survey of more than 1 million 11 to 18-year-olds. It's no longer now just considered as a law and order problem for the police to deal with. It's also sadly responsible for far too many tragedies in our society and a needless loss of life. And of course, as NHS workers, we often provide frontline care to families and communities affected by violence. It is critical that we address the root cause of this crisis and do more to tackle the reasons why young people are driven into carrying knives. Any response as professionals that you make must, of course, be balanced with the crucial relationship of trust and confidence between patients and clinicians, with, of course, the wider responsibility to protect the public. So today we have a superb speaker in the form of Martin Griffiths, who's a vascular and a trauma surgeon at Barts Health and works at the Royal London Hospital and of course teaches at the medical schools as well. He was appointed by the NHS as a National Director for Violence Reduction about 2 years ago in 2019. And it's a role aimed at breaking the cycle of violence and keeping young people safe. Now, Martin describes himself as a passionate advocate of injury control and has extensive experience in interpersonal violence reduction. In a written piece about his life, he wrote, and I quote Martin, but possibly paraphrase him, his love of trauma surgery is a remorseless and capricious beast that continues to beguile and amaze him on a daily basis. No case is the same, no operation without challenge, and no specialty is more unforgiving. Martin was an inspirational leader, or is indeed now, and a teacher. And Martin, I hope you'll forgive me for saying this, but he was a great team player, as he showed on the rugby field in his student days at Barts. Now, Martin loved his role so much that he received an accolade which I suspect none of us are going to get, but he was in the Independent on Sunday's Happy List in 2014. Just shows you how much he loves his life. So Martin, we're really looking forward to hearing your experience, but also hearing about the novel approach you have in breaking the cycle of violence that we currently see in our communities. So thank you very much indeed for coming. Thank you, Martin.
Well, hello, thank you. Thanks, Prof, for that introduction. I must forgive you, Professor Kumar goes back a long way. I was one of her medical students and I still haven't improved my knowledge of medicine in that period of time. I'm grateful for you for your support and inspirational leadership, but I'm afraid I'm still a humble surgeon at heart. Right, shall we go through this talk? So my name's Martin Griffiths. I'm a lot of things, but primarily I'm a human being who works in and around a community I love in East London. And my love of looking after those people has led me to work in vascular and trauma surgery, and that's helped me support that community in addressing the narrative around violence. Should we move on? Next slide, please. So this is me. In my two important guises, the one on the left is my work guise, and the one on the right is who I actually am, an inquisitive, smiling, and very naive young person who wants to make the world a better place. The guy on the left you see is one who was on work on Thursday, operating on a lad who was stabbed in the belly and was bled to death on me. He's fantastically well now, but he's a victim of this all-pervasive issue of serious youth violence that seems to affect the first world, particularly London, predominantly. Let's move on. So what is knife violence? Interpersonal violence, I think knife crime is a difficult term to divide, and we're going to talk about serious youth violence rather than knife crime itself. And it's important to understand why that's important. So society by itself is violent, and violence is endemic in how communities interact. However, the level of violence is slightly unusual. And interpersonal violence is driven by lots of things, predominantly lack of resource and inequalities. And it's exacerbated by a lot of factors, which include alcohol and some kinds of drugs, but more importantly, drug culture around it. And because of the nature of violence, it's predominantly seen in young people. So we talk more about serious youth violence rather than about criminality, because I'm not a criminologist myself. But most importantly, when we talk about violence, we have to understand that it is preventable. Let's move forward. So this is my old model of how I used to think about violence when I was first spun up as a violence reduction lead in London. I had a very autocratic, very fixed view of what the problem was. Violence was an infectious disease. We could attack it medically. We could look at root causes. We could do interventions. We could sort people out. We could tell people what to do. They would behave and then move forward. And that was great. It was very easy to understand in the medical way. It's very easy way to share with clinicians. But unfortunately, it is wrong. And it's very autocratic. It's very top down. It doesn't listen. It promotes activity about promoting understanding, and it's very, very, very grandiose about the benefit of humility. And when you try to work with communities to change narratives, this kind of approach doesn't work. It hasn't worked with COVID, and it's not working with vaccination. So it's important to appreciate that we have to be much more humble and listen to our communities who want to affect their hearts and minds. Moving on. So knife crime, it means lots of different people. For healthcare professionals, it probably means injury or perhaps sexual violence. To the police, it means knife-enabled crime like robbery, rather than injury. And to young people, knife crime just means fear about being unable to live in your society, being able to move around places, and being fearful of the community that you live within. The definition is quite woolly, but we talk about injuries that occur between people the age of 10 to 25 involving physical injury and classically a weapon. Now, with the government, they talk about homicide, and they talk about use of bladed weapons and also shootings. But I think we have to think very carefully about what it tends to exclude: domestic abuse and sexual violence. And I think they're very important to appreciate that the personalities that commit the violence in serious youth violence are also those who are committing domestic abuse and exploiting children as well. So I don't think we can just ignore domestic abuse and sexual abuse and child exploitation. We're talking about youth violence. Let's go on. So in order to give power to that conversation, let's look at the data around what we call victims, so people who have been injured by weapons. So in serious youth violence, the majority of them are male. A lot of them are hospitalised, and a lot of them have been injured on more than one occasion. And we'll often see that people have attended 3 times when they get a major injury into our emergency departments, and they'll have a history of going up to 10, 12, 15 times coming to ED with minor injuries, non-medical concerns, etc. When we look at domestic abuse, this is something that's currently experienced by females. And again, there's a cycle of violence and repeated violence. And the majority of people are in a space where they are active, but a significant proportion of them are deemed to be vulnerable by the community that look after them. Look at those people who've been convicted of committed offences, so-called perpetrators. A lot of them come from so-called broken families. A lot of them have a history of abuse, and a lot of them have a relationship with school exclusion, which is a very complicated and difficult one, which we'll talk about down the line. And there's definitely a correlation between not completing school and being part of the criminal justice system, be that as a victim or a perpetrator. But I think we have to think very carefully about whether or not we can use the terms of victims perpetrator to understand that sense of vulnerability and harm that we work in. Let's move forward. So I think that when we talk very traditionally about victims and perpetrators, people who get stabbed by other people. But unfortunately, in the world I work in, people often get stabbed for very weird reasons. So you might find that a young lad is being chased by a guy with a knife, turns around and stabs him. So who's the victim, who's the perpetrator? And I think we have to think more carefully about vulnerability, harm, and risk. I think we've got a large proportion of people who are vulnerable to being exploited and to be put into criminal situations, who are at harm, can potentially cause harm to others or themselves, and are at risk of being exploited or being victims of injury. And I think reframing the discussion in that sense, a more safeguarding sense, makes it much easier to understand the population that we're trying to serve, rather than looking purely at victims and perpetrators and criminality, because we are clinicians and health givers at our hearts, rather than being lawyers and police officers. And I think if we use those metrics of criminality and we use those terms of criminality, we start demonizing and we start stigmatizing people who are here to help, and that doesn't help us move things forward. Let's move on. So the elephant in the room is about ethnicity, isn't there? Because we noticed that the figures make it very clear that people of colour are more likely to be the victims and also the perpetrators of interpersonal violence, and that also bleeds through into how these individuals interact with authority. So for people of colour are much more likely to be stopped and searched, or be involved in the criminal justice system, and to be convicted of the same event, as are they likely to be excluded from school, or to experience bad outcomes in terms of mental health access, mental health experience, and also quality of their experience. So we have to understand that ethnicity in itself leads to issues with experiences which are adverse in terms of their experience of authority in all its senses, be it healthcare, be it education, be it social services, and that poor experience in terms of access, experience, outcome, and being demonized affects people's attitudes towards crime and criminality. More importantly, when we look at the most likely the causes around violence, the issue is more about lack of resource, about poverty, than it is more about ethnicity. And it's important to ask a different question, not as why are people of colour violent, but it's more why are people of colour poor. And we'll come back to that later on. Let's move forward. So institutional bias and disproportionality is something we're going to see an awful lot in violence reduction, and it's been brought out into very clear focus during COVID. We've noticed that people who have in these spaces have different attitudes towards authority and how they interact with law enforcement and healthcare, and they've experienced poor outcomes in the past, and therefore are less likely to engage in top-down autocratic programs and need to feel like everybody else does to be part of a problem, part of a solution, and part of its delivery. You need a hand on the wheel. More importantly, you have to think about how the larger community views the areas, groups who are focused on in a certain field. So people will very quite rightly ask questions of the modern black community and other ethnic groups, such as gypsies and travellers, who are equally targeted in terms of violence, in terms of vulnerability. Why is that these groups act in this certain way? And I think it's important to appreciate there's a much more complex story behind that, and needs to be a different conversation around why these groups are in these places before we can actually have stronger conversations about how to change a narrative. Let's move on. So the big thing I get asked about is about gangs and gang violence. Isn't it all about kids and gangs? And the problem with that term is that no one knows what a gang really is. A gang can be anything from a collection of young people who sit on corners through to organised crime. And if you look through the literature around gangs, it tends to coalesce to saying it's a group of people who have some sort of a bond, be it geographical, ethnic, or whatever, that are more likely to be violent or involved in the criminal justice system. And that includes the Boy Scouts, it includes the All Blacks, it includes lots of street gangs. But in terms of understanding youth violence and youth groupings, it's important to look at recreational, criminal and enterprise associations. So more often than not, young people, young adolescents group in corners geographically and self-label themselves with easy access, and then involved in groups that are mainly recreational and social, and there might be some more criminality around that. As time progresses, you get saying people will migrate towards more criminal activity with a more closed membership group, which you are recommended to, and there maybe will be some rituals and entry towards it. And these guys will correlate to, will congregate around delinquent behaviour and violence. As you progress from a younger to an older, and you're in an adulthood, you then become into proper business, and you become perhaps a regional or branch manager, and you're now looking at making business, making money out of what you're doing, and that often is around the drug and the drug trade, and that will put you in a different space, different activity, and the violence in those spaces is not sporadic, it's focused. Recreational violence is very much about he said, she said. Criminal violence is mainly about gain and loss, and enterprise is really about focused deterrence. The interesting thing about gangs, and this is really quite important, is that true gang violence is relatively uncommon in CSU violence. Only about 5% of the violence that we see in bladed weapons relates to true gang activity. The majority of it is young people in social groups who interact and resolve their conflict with violence. So gang focusing is a challenging and difficult concept to bring into our program. So focusing on gangs predominantly isn't necessarily a fruitful way of moving things forward. Let's go on. What is important, however, is look at the impacts of youth and growing up, and the concept of adult childhood experiences has been around for a long period of time, and my colleague Mark Bellis has done some beautiful work in Wales to understand this better. In broad terms, the traumatic events growing up in childhood around abuse, neglect, and dysfunction in the home lead to an increased likelihood of risky behaviours, health conditions, and early death. And it's an indicative rather than absolute guide. I don't come from particularly storied background, and I've been relatively successful in my career, and you can't simply say you were brought up poor in a difficult situation with violence in the home and drugs, and that means you're likely to be that person, but it doesn't speak towards your vulnerability towards abuse and becoming a victim or perpetrator of violence. Let's move on. More importantly, it's important we should try and appreciate the impact of these adverse childhood experiences on the developing brain, and it's very good data around how that traumatic experience can affect the neurodevelopment of the brain and in younger people, and result in more measurable forms of modulation and dysfunction. What's important to appreciate in young people who are brought up in traumatic scenarios is that rather than being broken or different, people may well have adaptations in their behaviours to allow them to cope with stressful scenarios, which might be seen as being behaviourally challenging. And that plays out in the educational space, where people who have these adaptations behave in a manner which isn't perhaps in keeping with what people are supposed to do at school, and that might lead to a much more likely event of you being excluded from school due to be difficult or challenging. And it's important to appreciate very clearly that a large number of people who in the criminal justice system, particularly those who have been imprisoned, have evidence of neurodysfunction and neurodisability that hasn't been diagnosed. And lots of people with things like autism, other kind of learning problems, which have not been picked up in early life and have contributed to vulnerability. And this has to be addressed at an earlier stage to minimise the risk to these younger people. Let's go on. So this speaks to us of changing our attitude about how we talk and listen to people. Trauma-informed practices is a widely understood piece of work. But it's based around one simple question: what happened to you to put you in that situation? I'm sure you've all met individuals who have got challenging behaviours, who aren't diagnosably have mental health problems, but destined to be very difficult to understand, and they've been traumatised in a scenario in ways that you don't understand or appreciate. And in order for you as a clinician to interact fruitfully with that person, you have to think about the traumas that are existent in that individual, also within yourself, and how the environment which you're interacting with them contributes to that poor interaction. And it's about trying to be slightly more forgiving in your understanding of how that person behaves. I've been shouted at and screamed at by lots and lots of parents of young boys who've been stabbed, not because they're truly angry with me, but because they are scared for their children's well-being. And this mechanism of communication is the only way they know how to get across their concerns. And if you don't understand or appreciate that, you might take it personally about being screamed at or wrestled to the ground by an angry parent. It's because they're upset and they're trying to explain themselves in a way that makes sense. And adaptations are important. More importantly, when you've got difficult and challenging behaviour you see in your colleagues, it isn't all about the scenario itself, it's about the backstory. So please try and be more forgiving and thoughtful in how you interact with everybody, not just your so-called patients, but also the individual you work with, and appreciate how your own personal backstory has affected the way you interact with the community that you serve. Let's go on. Now, a couple of concepts about competence and credibility that are very important when we're talking with younger people, people from backgrounds that aren't necessarily the same as yours. And cultural competence is simply a construct to speak to those talking about saying that I want to understand your issues. It's teachable to understand. It's about trying to be more open to the circumstances around a person's upbringing and behaviours that let you understand things better. And that's around trying to be slightly more open and less rigid in your thinking about behaviours and adaptations. It's very easy to want someone to template their behaviours on your own experience. So if you grew up in a particularly difficult lifestyle and you've made good on your life, you will believe that your way is the only way to do things. And that's all very well and good, providing that makes sense to a younger person. But talking to a 13-year-old boy about going to school and working harder and going to uni makes very little sense if you live in Beckton. And then in your home has never been through school, let alone completed it, and the university education and employment itself actually is a pipe dream. And the life that person might want might not be agreeable to you. You have to temper those expectations, and more importantly, want to understand where that person's coming from. Let's move on to the other concept around this, cultural credibility. Can you move on, please? So we can talk about people wanting to be culturally competent and understand more, but there's also a piece about how you engage with people who aren't from the groups that you don't necessarily represent. And there's a huge piece of thing to understand that you can want all you want to be credible in a space, but you can't necessarily be that person. I when I was younger, was very credible with young black boys because I was a young black boy. Now I'm an old middle-aged, middle class. Middle England man, I'm not quite so credible in that space, although I talk about other things. And I think it's important to appreciate that you have to, when you're walking with younger people who are vulnerable, they want to feel a connection. And these people are incredibly talented, incredibly perceptive in terms of how people's integrity and authenticity strikes them. So it's important that the individuals who we choose to allow to interact with these vulnerable individuals at the front line are culturally credible. And that doesn't mean necessarily looking like somebody, but it's about the language, and it's about the understanding, it's about the concepts around it. And much as I love talking to young people, I find myself talking at young people sometimes. I need to modulate my behaviour and my tone. And it's important to appreciate that some of the times, no matter what your skill set might be, your learning or your education, you might not be the right person to talk with this person at this point in their journey in violence or society. So you might well need to bring in an expert or by lived experience, somebody who has an understanding of the cultural narratives in the society you're serving and has an appreciation of the concerns that person, and more importantly, their parents might be seeing in that space. And cultural credibility is key to capturing people who have poor experience of authority, who need to be empowered in that space to interact with authority and then make their own direction to how they want to move forward. So please bear that in mind when you're interacting. Let's go on. So a question I get asked a lot is, what is this public health approach? What are we talking about when we talk about trying to fix this problem? Is it about public health in its truest sense? Is it about collecting data and looking at pros and cons and developing solutions and interactions and alternate practices? It's not simply that. And is it about sharing information and saying kumbaya? Absolutely not. And is it about just collecting data? And the answer is yes and no to all those things. The public health approach is is definitely evidence-based and data-driven, but it's about collaboration, and it's more about working outside your traditional clinical or professional silos to understand not just the problem at hand, but the narrative behind the people who have chosen to work in this space and where their individual biases, conscious or unconscious, sit in that space. There's an awful lot of unlearning to do for all those concerned, and it's about us all working together from our social care, healthcare, policing, education backgrounds, and local government backgrounds to take away, strip away the net narrative of bias around what we feel the problem might be, and to work together looking at the data, the evidence, and looking at solutions which are actually effective that allow us to engage with the community at a level that's empowering and move the agenda forward. But we need to have data, we need to have evidence. Let's move on. It's important to appreciate what these opinions look like. When you talk to police officers about public health work, they talk very much about Thrive, talk very much about the 4 Ps of policing, talk about situational policing, and look at it as a criminality issue. We talk to social care people around public health. They will talk about initially familial safeguarding and that extra-familial or contextual safeguarding, and that's again about trying to look at risk, vulnerability, and risk in terms of harm to younger people. And health people look at things even in terms of violence and injury for their ED kind of focused people, or talk about the true public health approach, looking at data and its collection. And all of these 3 groups of individuals have huge utility in this space, but have to unlearn and work together. And it's about piecing together this narrative and combining it with local government and central government to try and develop a program which listens to the community and gains the community's trust and works with it to understand where things are. This is not an individual piece. It's about trying to create an environment where people can make their own choices, which are owned, controlled, and inherently safer. Let's move forward. So the question, as in the talk, what does healthcare do? And it's a complex question. The question answers a very simple question. I think the first thing to say is that we can actually do our jobs really, really well and provide the best healthcare we can for young people with and without trauma. And that's about looking not just at how we treat the victims of injury, but how we provide support to the mental health needs of people deemed victims and perpetrators. And we do a lot of work around how we rehabilitate perpetrators to try and make them more comfortable going back into the community and into society. And it's something we have to broach. It's a very difficult situation to invest resources in looking at people who've been convicted of crimes and how we change their attitudes towards violence. But it's important if we're going to reduce violence that the whole gamut of society is approached and supported in the space. We have a role in education. We need to really think about how we, in the health space, what we do about trauma-informed practice, what we understand about what violence is about, and how we interact with in the educational space and in other places to share our knowledge and experience and learn from other people who understand the situation better than us. And this phrase, experts by experience, okay, or lived experience, is a key tenet in understanding how we as healthcare providers have to get off our high horses and listen to individuals who have more expertise in this field to try and understand and move forward with working with rather than for structures, and actually trying to be much more constructive and empowering in what we do. It's not about me telling you what to do. It's about us working out what your skills and strengths are and how we can make your life better, so that the byproduct of that is you being less likely to be a victim or perpetrator of violence. In healthcare, we have great access to data. We have great data about admissions, about injuries, about mental health, about societal determinants, and we should share that information transparently with other stakeholders to better supplant the information around that space. And that should be linked with data around education, about social care, about governmental data, to give us a rich database to draw some information around that and then devise novel solutions, okay, which can be assessed and measured. The problem we have with healthcare measures that we use healthcare metrics to measure our margins of success, like readmission rates or wounding scores, and they're not really that helpful when you're trying to measure the happiness of a society. And I think that we have to recognise that the emotional well-being of our community is key to reducing violence and violent behaviour. And if we don't address that at an early stage and provide that much more supportive work, we're never going to get to the point where we actually look at how we reduce that physical interaction. More importantly, as healthcare providers, we have a huge role in advocacy. We can speak in any space because we are those trusted voices. We are neutral. We are always working to improve a lot of the people we serve. I use the word serve blatantly. And I think that the majority of the population think that healthcare workers are trustworthy, honest, and have integrity. And it's important to appreciate that advocacy role. Your patient will ask you what to do about all manner of health and non-health related issues, and they will take you as being a reasonable voice, much more so than local and national government, particularly in the current circumstances. More importantly, as healthcare advocates with strong data, we can talk to the same stakeholders about our experience in that space and speak with absolute clarity about what's important. For us as healthcare people, we have to also have robust positions about what we think about domestic abuse, exploitation, assault, and as far as I'm concerned, violence, because we have the data, we have the understanding, we have the integrity to look at this data objectively and speak truth to power about what's important. Let's move on. How does that manifest in practice? I mean, it's all sound very woolly, but what we need to do is actually do things that are actually practical. And in my practice, that means actually collecting and sharing data. It means interacting with communities in a way that's empowering. It involves working in the healthcare space, but in primary, secondary and tertiary care. It means educating ourselves and our community. And it also means changing the nature of the mental health offer to both our community and the victims and perpetrators of interpersonal injury. But most of all, it relates to us having an entirely reframed way of dealing with and interacting with our community. It's about getting down to the ground, listening to people, and actually allowing us to not talk in terms of control, but in terms of empowerment. It's very easy for clinicians to medicalise issues and prescribe happiness and prescribe activity and prescribe behaviours. What we need to think more about is how we can empower individuals and not give away power, but actually make everybody in that space more powerful. Let's move on. So the first thing we can do is collect and share data, and the biggest model of that is information sharing to tackle violence. And it was started off in the chat in Cardiff by John Shepherd, a Max Facts professor, who's a fantastic guy and a tremendous clinician and a real innovator in this space. And collecting and sharing data around violence in Cardiff at night, young lads who were punching each other when they're drunk, led to better policing, better outcomes, and a transparent sharing, but more importantly, a better relationship between the emergency department and the criminal justice system and the community safety partnerships that worked in that space. And that allowed us to do more to reduce violence in that space. And that process of transparently collecting and sharing data around assault with stakeholders as a model to move towards ISTV and allowed us to actually do much more than just do work around policing areas, but actually to put in place proactive measures to try and support areas of the community which are at risk of violence. Let's move forward. So now we've got that data in hand. We can now combine that information around health with other data sources like education, etc. And we can implement proactive measures to cover geographical areas, to cover schooling areas, to put in place issues around anything from safe serving laws through to licensing restrictions, through to how we can invest in certain estates and schools to support individuals who might be at risk. We've moved the whole idea around data collection forward because all level 1 EDs and treatment centres are now required to collect and share data about violence transparently, and we've moved that from being a local from EDs to the local community safety partnerships now to going to a central resource, and now we've digitised the entire data collection system. You might have heard of the ECDS. We're now in a position to move forward with a pilot which I'm now serving at London to actually collect this data and put it centrally and allow that large level of data to be analysed centrally and give us much more power. If you move on. What we're hoping to do with our data collection now is to collect a large amount of data, analyse it centrally, and then recite that back into the effectors in the local regions with much more power. But it gives us access to a huge amount of data to look at trends, look at issues, and be much more powerful in thinking about novel solutions that work not just locally but regionally and nationally. And I think this is a really exciting development, how we collect and share data to move it from beyond being a reactive process to being something we can look at to try and develop novel solutions to be more proactive. And it's about collecting actionable data. People get very caught up about acceptance rates, getting 90% rates or 80% rates. What I want is enough information to make a good decision, and that will come from a broad base of robustly collected and cleared and shared data, which is anonymized to allow us to make those difficult decisions around bulk metrics. Let's move on. Training and education, and I've spoken quite passionately about the unlearning that needs to happen in terms of resolving conscious and unconscious bias. But we also have to have a basis to work from, and we in NHS England are putting together a training package that brings together the best of the currently available educational resources for around violence, and put that into our safeguarding 1, 2 and 3, and also develop some novel modules for those in the healthcare space to learn more about violence reduction and its programs. We look towards having a formal suite of information, scenarios, data, training, etc., to allow clinicians to work within the space and also broadcast that message outside the educational space, outside the healthcare space, to schools, etc. And it will, and we link this work with the FE to try to bring some of our training into the level 2 and 3 of key stage 2 and 3 of education, and try and get our learning earlier in the piece. We've got support from the Royal Colleges, and we will also have a model of healthcare champions, which I will be advocating this. I'll talk about that later on in the talk. Let's move on. More importantly, we also have to support the education of our community, and I think that's about talking about curriculum change. And I'm very keen to get into primary schools. Yes, primary schools, teaching parents, teachers and children about what violence and behaviour looks like. It's about healthy lifestyles, mental health, about conflict resolution. It's about trying to understand how people adapt to difficult scenarios and trying to reduce the friction and heat in those conversations. We can use whole school approaches, mental health approaches, school nurses to signpost individuals who are at risk or vulnerability, and we can use those educational spaces to try and change what we're doing. I think it's important to appreciate a lot of what we're going to do in violence reduction is going to happen non-medically in those non-healthcare spaces, providing advocacy and support rather than actually prescribing happiness. More importantly, we have to have a very clear and stringent message to the public about what violence looks like in terms of cost, in terms of both physically and emotionally, and also try to inspire positivity in our community, trying to create conversations in those important spaces that we don't reach as clinicians, to start that social movement to look at violence in a different way. If we can get young people talking about violence in a much more constructive way, talk about themselves as positive individuals and being empowered, we can reduce the need for people to feel that they can only become significant if they are the victims or perpetrators of violent activity. Let's move on. Enough of the lofty. Now, I've talked very clearly about trying to demedicalise the interaction between healthcare in trying to promote opportunity. And unfortunately, social prescribing is a really fantastic methodology for us to empower individuals in terms of that frailty and vulnerability to offer non-medical solutions in the healthcare space to individuals who are at risk. And in the model we're developing in NHS London, look towards supporting vulnerable youth and vulnerable families to a whole suite of opportunities to divert, empower and support young people into the financial activity, educational support, mental well-being. This is facilitated via social prescribers or link workers who may well be healthcare trained or may not be healthcare trained, but have a generic set of skills and work within either healthcare spaces or get referrals from healthcare practitioners to deliver this work. It's very, very soft. It hasn't got to be very clinical, but its effectiveness, I think, is going to be very, very important, particularly as we move towards the ICS model later on this year. And I think that the opportunity for us to interact with individuals before they trip any kind of violence metric or excluded from school is the key for us to actually to kickstart our community thinking more safely about how it interacts with itself. And I believe that this model of care, this opportunity to interact with people way before they become victims of violence or are acting out at school, is an opportunity for us to empower familial groups, parenting groups, to support the young people in a better way, and also for parents to understand their children and the societal stresses around that in a much more impactful way. Let's go on. Mental health. So we all know from our experience in the past year in COVID what mental health looks like on a personal level. We've all been exposed to the rigours of lockdown in various shapes and forms and doing things we didn't used to do in the past. And even for those like me who are resourced and supported, I found it very rigorous for me. Now, what we recognise now that even in less resourced parts of the community, with less access to support, the mental health of our nation has really been a huge issue. And in terms of how we address the mental health needs of our community in and around violence, there are two aspects to that, really. I think it's about understanding that we need to support our communities better, so have a better appreciation of what mental health and good mental health looks like. And we need to do some work around the what happens to people who are victims of trauma, be it interpersonal or not, to understand how physical trauma affects your mind and your likelihood to behave in the future. So it's a two-pronged attack to addressing that. Can we move forward, please? And I think that what I'm hoping is that what we've done is we put together a couple of models with Peter Fonagy and Sherry Peck from our big group in London to try and develop some models to allow us to move that forward. And Claire Murdoch and her, again, NCD and her team have been incredible supporters around this piece of work, and we've got some really great ideas to try and fund some offers to actually change what the offer looks like to our communities, and more importantly, what the offer looks like to the victims of trauma, to allow them to work more effectively in the mental health space. Now, I spoke to you about the Violence Reduction Academy, and that's about trying to coalesce the learning, the practice, the experience around violence to give us an opportunity to have a resource of information, to have a discussion space and a training area to actually empower healthcare workers and non-healthcare workers to understand violence much more actively. That program has been green-lit. The funding is now in place, and I'll be establishing a program at Barts Health initially to run the academy for London. And my expectation will be that this will snowball as the community builds to deliver this output, and we'll be able to host not just conversation and discussion, but information, training, and evaluation for programs and for people who want to work in the space. So this is a really important key to actually developing that learning engine, allow us to deliver work in a much more considered and thoughtful way, to be driven by evidence, and will allow us to find where data exists if we haven't got it already. Let's move on. So what do we do in terms of what we do in practical things? So when we talk about primary prevention, about the community, what have we done in the past? What can we exploit? We can look at shaken babies, look at parenting. We can look at how we support disadvantaged families in the early stages. And there's good work around the impact of supporting disadvantaged families at the start of their parenting journey with great effect in terms of how mental health and violence looks. I think we know that school nurses are fabulous clinicians who work very closely with young people and have a great sense of what their needs and wants might be, but there aren't enough of them and they aren't supported in the appropriate manner, and they need to have better training, better support and better numbers. We know that when we look at how we support young people's mental health, we can define a better pathway of support that is more effective, more transparent, and works in a space that isn't in the healthcare environment. And we can, with those bits in place, we can support individuals way before there's a problem, and we can all, and that's a general offer we can offer to every person in that primary space to decrease the level of presentation of even dysfunction at the very earliest of stages. This is all happening in primary schools, in maternity units, happening way before we get to any kind of recognisable violence or vulnerability, but it's about vulnerability and reducing harm and reducing risk. Let's move forward. We also look at how we can support older people. So we know that when we look at younger people, we can mentor. But when we're looking at older young people, they look to us gaining skills. And for me, one of the most practical skills we've developed is teaching bleed control training. We teach hemorrhage control to young people in our community to help them and themselves when they've been injured, and use it as a bridge to a conversation around citizenship, around behaviours and how that work. More importantly, use it as a means to get kids into healthcare employment with the Healthcare Horizons programme. And we've seen this thing being really effective in lots of ways. Number one, we've had kids who've actually been injured, who've had their life saved by applying tourniquets in the field and come to us alive when they would have been dead. This young lad in Croydon died on the weekend. He would have been saved if he had someone pushed on his groin. And also we've used this process to develop the talents of individuals who were thought to be unteachable in this space. I've got a young lad who a year and a half ago was on a corner, who had picked up one of our programs, taught the bleed control methodology, became an alumnus, became a trainer. He's now volunteering in our program. He will be working within Barts Health in the next year or so. And that's the power of giving somebody skills and supporting their development and empowering them. We can take somebody who is unrecognisable, unsalvageable, unreachable, but by giving that opportunity to access skills and training and using that as a bridge towards empowerment, you've created a useful individual who is now reflective, a great communicator, a really passionate advocate, and a real amplifier in their community. And that's the power of what this work can do. Let's move on. Like I said before, when we also work with people who are at risk or have been victims of robbing, done some great works in court, done great works with the court, with deliveries around trying to support individuals there. A lot about psychological support people who are victims and perpetrators of work, and we've done some really nice work in trying to understand individuals who are at risk of violence. So those people who have presented to liaison to custody suites, those people who are in and around the criminal justice system, those who have been identified as being nominals via the various matrices, and these are individuals who, if we support and challenge appropriately, can be empowered to change their view on what good looks like. Okay, I think what social program can be really powerful. Let's move on. And then we've got individuals who've actually been hurt. We can do work to reduce retaliation and readmission. And my story in my instruction starts with me doing work in my own trauma centre, trying to support young boys and girls who've been injured. And we were in a situation whereby we had young men we were seeing 600 to 800 stabbings a year admitted under our service, who had a readmission rate of about 35–40%, because they were that driven to behave in that manner around violence and retaliation. They were obliged to seek out those who hurt them because they had no faith in any other system. By putting in place individuals, this is Justice Roisin Kevill, our senior caseworker from St Giles Trust, one of the 3 great charities that work in that space. Plaudits to St Giles Trust, to Red Thread, and to Oasis, done that work in London. Those groups have been incredibly powerful into providing individual lived experience who sit between healthcare and law enforcement, but work for the client, for that young person and their family, to navigate that space in hospital, to understand violence and how it's affected them, to do a model of social prescribing, providing that needs assessment and empowerment model, and seeing how it works. Now, it sounds like a load of woolly nonsense, doesn't it, from a surgeon? But this piece of work was groundbreaking for me and for our unit, because our readmission rate went from 35% to 1%. The Major Trauma Centre changed its readmission rate by an order of magnitude simply by listening to people and offering them pragmatic support, which was not medical. And our attendance to clinic, our adherence to clinical protocols and behaviour on the ward improved almost overnight. And the feedback from the families, particularly the mums and dads of these young people, was incredible. And more importantly, the siblings who were on a path of destruction changed their minds and went back to school. Just by putting in place individuals who would listen, who weren't preaching, who weren't teaching, and who weren't trying to shape people in that autocratic manner, we were able to reach individuals and allow them to think carefully about their space in that so-called reachable rather than teachable moment. And that for me was a real eye-opener about how I have to change how I do what I do. Let's move on. So the future. Well, ministers aside, we've done an awful lot of work about trying to embed these programs in London, and we know that as part of what we've done in London, we've proven that having a healthcare lead who works within advanced reduction units and within the spaces has been effective in changing the advocacy and delivery of healthcare in those spaces. I think from more importantly for me, we've now got a much more robust way of collecting and sharing data, and that's important that we understand that we look at what we're seeing, and also that we understand not just healthcare data but other kinds of data like social care, educational data, and it's collected robustly, shared transparently, and interpreted objectively. Also, we're going to, as I said before, we've now got green light funding to actually expand our work, and over the next 9 months we'll be working with HEE to put together a better training package for all concerned, not just the healthcare workers. There's nice work going on with school nurses, but there's other pieces coming out from there. In terms of the whole thing about social movements and about ambassadorial work, yes, we're developing a piece of work with the Advanced Reduction Champions, initially in London, and that's going to be a parallel piece of work with the police, done with the VIU and the Met, to try and produce champions and ambassadors who understand the practical skills around it. Our Your Stance programme is being expanded, the Bleed Control training programme is going to be expanded across London to deliver that kind of support and guidance to those about bleed control. And this work won't be done in schools, won't be done in hospitals. It'll be done on street corners. Young lads who aren't reachable by traditional means. We'll be teaching guys who are nominally in gangs how to do bleed control training, so they can be shown that they have a pathway back towards a more central part of society. But most importantly, guys, what we're going to try and do is try and engage our community in driving their own care forward. We've learned from personal experience right now that if you don't listen to people and talk to them at ground level, you can't hope to change a narrative. We can't prescribe happiness, we can't prescribe behaviour. What we can do is listen and learn and trying to find a way forward that's mutually agreeable and gives people an element of control in their own lives. Let's move on. So to my mind, good looks like this. It's about me being trauma informed and me being recognisant of what I'm doing, me being more forgiving and more understanding of what I'm trying to do, and trying to see the good and possibles in everything I do in my clinical practice. For my institutional, it's about us being much more about trauma informed practice, more about having a bit of about policy and having more of an idea about how we prevent violence and how we support individuals in those skill sets. For me, it also is about having ideas about how we collect and share data, how we as healthcare people advocate for violence reduction in the spaces that we all work in. Whether or not you're a high volume centre for interpersonal violence, you will see young people who are at risk of violence, who are vulnerable, and you can shape their directions by supporting them, providing advocacy and perhaps referring them to appropriate services which aren't medicalised, to provide support and empowerment to them and the family groups around them. And we can support the VIUs and local groups as well. And also moving into the bigger strategy to talk about policy. And that's about supporting and sense checking policy, be it serious violence duty, about collecting and sharing data, the Weapons Act as well, or about, I've crossed out alcohol pricing on the ground. It's far too controversial for this forum. But I think that if we look at how we can interact, how the activities of reducing sugar in drinks has led to a better control of medical well-being, we can see where there's potential opportunity for us to think more carefully about how we can talk about bigger policy to interact to affect change in our society. Let's move on. So some tips to go away with. Really, I think it's important that you as a person or an institution are culturally competent, you're relationship based, and you try and get people to be empowered rather than seek your help. And it's about hope and trust. It's about you installing the sensation that people actually can improve their circumstances by actually actively engaging in the process, and they can be counselled through failure to understand what failure looks like and to move on rather than dropping their heads. And it's all about agency, and it's all about empowerment, not red but green. Put more positive in there rather than telling people what not to do. Let's go on. We talk about method. It's about co-production. I'm not going to tell anybody what to do. I'm going to work with community groups, take their advice, and rather than taking the ideas, put that person in my program and let them run the machine with a hand on the wheel, and train them up to deliver that work better. So we can create an individual in that group who drives the program, who speaks in the community, has authenticity in that space, has integrity in that space, and delivers real change in line of sight of their siblings and partners and community members, okay? We're going to be family based, okay? We're going to try and look at groups, okay, and try and think about being more supportive and therapeutic, but train skills in other people, okay, and think differently about safeguarding, rather about familial risk, about extrafamilial risk, about what places and spaces look like rather than individuals. And lastly, moving on, implementation, okay? That's about working across agency, across barriers. We've done some great work in county lines, and done some great work about trying to share how interdisciplinary work is really effective when we're both on the same page. And it's about training people to facilitate practice rather than having a specific designation as being a healthcare provider or a law enforcement person or a educator, but having generic skills that are effective in all those spaces. And it's about making sure that our interactions occur in a stable place. And that can be physically or it can be virtually. And the advent of technology like this meeting today is a prime example of how we can be effective in spaces without having to be physically with somebody on a minute-to-minute basis. Let's move on. Try and avoid a few things. Try and avoid to be in and out, just off to preach and walk away. Avoid the red and just say don't do stuff, yeah. And try and avoid just telling people what to do. That's not going to help anybody, okay. And more importantly, for those like myself who've got long backgrounds in this kind of work, try not to use your experience as a weapon to beat other people over the head with when you're trying to change policy, okay. And you need to be very, very thoughtful about how you interact with people and be sensitive to that interaction. Okay. The biggest problem I see in some places, people tend to disregard people because they don't quite fit a metric, be it an ally or an opponent. I've got a picture there of John Carlos, Tommy Smith, and more importantly, Peter Norman, the guy on the left who sits there, whose gloves were there in Tokyo in '68, who suffered as much as anybody else there from making that statement. And Peter Norman was an incredible ally. The Black Power movement was an incredible ally towards understanding and uniformity, but he was disregarded by lots of people because he wasn't black. And that's a terrible tragedy because he was an incredible individual who was pilloried by lots of people for not being the right person, but he was an incredible ally and should have been supported throughout his life and is now celebrated quite rightly for his interaction in that space. Lastly of all, please try not to get involved in the drama of supporting individuals. It's great to be the hero, it's great to provide support, it's great to answer questions, but please don't get involved in the drama triangle and don't make the persons you're trying to support dependent upon your activity and advised to do anything in their lives. You have to be a person who allows someone to walk into a clinical space and walk out of it as need be. Do not fall into the trap of people into a medicalised pathway they can't get out of because you won't let them. It's about the soft touch, about the gentle touch, about the supportive aspects of your clinical skills, not your ability to put them into a pathway and let them settle on that for the next 10 to 20 years. Let's move on. So what have I learned? The whole journey of this period over the past decade has changed what I am from being autocratic to be much more of a listener. And I think I've changed the way in which I interact with healthcare and also with the communities to be much more about advocacy and support rather than being autocratic. I think I know that people have to trust me, and that's about me having integrity and authenticity. Okay, but that's going back to by data, and nothing will change in any of the face of work without the information around that. Metrics might be different, but the data is important. Okay, let's not try and make a social problem medical. It's not an infectious disease. Okay, it's something you can't inoculate a population against violence. What you can try and do is understand it, and by understanding your own bias. By making it a medical problem, you should understand why clinicians in the past have failed to address this problem for year upon year. And please try and get rid of your misconceptions. They're really disempowering, they're really unhelpful, and it's important to do a piece of work around unconscious bias before you even start doing this work, because it's really, really helpful to make your life much more powerful. Let's go on. So my final statement is written on the board, and it's there for you to read. David was a guy who worked in procurement at Barts. Lovely guy, graduate, and his father died of COVID in the last lockdown, and he was murdered coming back from work one night for no reason. He wasn't a gangbanger, he wasn't a bad person, he'd been to uni, he was a tremendous guy, and he was murdered for no reason. In the society, didn't understand who he was, why he was, and his parents are stigmatised because he was a victim of interpersonal violence, and that is a tragedy. So for me, this talk is for David, because he is the kind of person I want to see doing well in life and not to be a victim of interpersonal violence. Can I finish this by acknowledging the people? Next slide, please. I've got a picture of the advanced action team that won the BMA award. And you can see Rushing Kevil in green. You can see the Guinness guys and John Giles either side of it. Myself and my CEO Jackie Sullivan there, Mike Carver, our VRN, and our water staff on the extreme left and the tow guys on the extreme right. We're a huge team doing a huge amount of work, working together to understand and support people. Roisin is the linchpin of this program at the Royal London because she understands everybody. The clinicians, the patients, the parents, the staff, the system, and her skill set, her unique skill set to interpret and manipulate that space is key to us understanding better. And our healthcare system, our care, our practice, our understanding is better for her work and her genius. Thank you very much, indeed. I'll stop there. Thank you.
Wow, Martin, that was a tour de force. It's left us all breathless, I think. I mean, the complexity of it, the children, the family life, the education, schools, society. I mean, it's as you say, it's all our problems. And it's interesting also that you came down at the end by saying the one thing that really matters is listening and making people feel that they're involved. So thank you very much for that. And I think there are lots of questions coming in. So I have to say, I became very depressed, but I think at the end of it, I felt there was some hope there as well. So one of the questions that came in was, do you think that the nature of knife crime has changed with the lockdown restrictions?
Absolutely. Can you guys hear me? Because I've frozen on the screen.
Yes, I've frozen as well. I can hear you though. So I assume everybody else can.
So you put me in a sort of phase, but so yes, lockdown had a significant impact on interpersonal violence. It dropped by down to about 1/3 in the first lockdown, little numbers, but the devil's in the detail. So the serious youth violence is very interesting. That the on-road stabbings dropped off to a very little level, but there was a slightly smaller drop in the victimization of women. So women were still being stabbed and beaten. But in the home. And although there's not a lot of hard data about a massive increase in the physical aspects of domestic abuse in lockdown, we are very clear that during lockdown we saw more in calls from individuals to police for support around domestic abuse, more attention of the ambulance services to see people who have been interacting in domestic abuse, and I don't think a statistically significant rise in actual injuries we saw in our major trauma centre, but definitely more going on. Have I locked out completely now?
No, you're in now. No,
okay, fine.
You were in a second ago. No.
Oh, here I am. Here we go.
Yeah.
Okay, right.
Jess, over to you.
So thank you very much, Martin. That was fantastic. Quite a whistle-stop tour. So I'm going to take. I'm going to abuse my position as deputy chair and ask whether availability of knives correlates with the amount of violence.
Yes and no is the answer. I think a bit like guns, a knife is a knife is a knife is a knife, and people are killed by deadly weapons, killed by bottles, killed by jars, killed by all manner of things with got blades on them. I think that the giving young people access to very harmful weapons like zombie knives is pointless, and that was put into policy a few years ago. I think it's important that we don't just let individuals pick up weapons of potential harm willy-nilly, but you can get them off your mum's kitchen drawer if you want to. And I think that what we have to do is be very clear, not just that weapons access is minimised in terms of you can't buy weapons of massive harm from internet retailers or from shops, but more importantly, we send a very clear message around what you can do with improvised weapons and making sure that parents understand where their instruments are going in their home.
Okay, thank you. And we have some pre-submitted questions which I'm going to go through now. Is knife crime related to poverty and deprivation, please?
Simple answer is yes. But again, devil's in the details. So if you look at Liverpool and Newcastle, very similar demographics for very different levels of knife crime and violence. I think that relates partially it's about social cohesion, understanding, and what communities are about. I think that equal, fair, supported communities with a clear mission have a much less likelihood of being violent. And I think that the groups that are coherent and supportive tend to resolve conflict in better ways. But you're absolutely right that inequality and lack of resource makes you vulnerable to being a victim or perpetrator of violence.
And on a similar theme, there are some submitted questions which I'm going to make a composite question of. Mental illness, ADHD, drug addiction. How do these correlate with violence and what can be done about it?
Okay, brilliant. Okay, fine. So there's no good data that suggests that diagnosable mental health injury in illnesses make you more likely to be violent. So not a perpetrator. There's some good data around alcohol and violence in terms of vulnerability and causing harm. And there's some soft data around certain forms of strong forms of crack, etc. But it's all very, very woolly. So substances, I think, are a bit of a misnomer. It's more about the drug culture mindset around it, about the me and mine culture and that very nihilistic lifestyle, rather than actual substances in themselves. I think that it's more about vulnerability than it is perhaps around to being harmed rather than being a perpetrator, as it were. And I'm very mindful to delineate aggressive behaviour and challenging words between physical activity, and I want to be very clear on this, that I can see no correlation between mental health and the ability to perpetuate acts of violence. And I do not buy that that most drugs of abuse makes you more likely to be violent, but I do accept that the drug culture itself, okay, and the mindset around it makes you more likely to use violence as a resolving issue.
Thank you, Martin. I have a question from a Band 5 public health nurse. She is just currently finishing off her master's in public health. How can I use this qualification to support tackling knife crime within my trust?
So what I would say to you is I'd put the qualification to one side, and I would use the amazing engagement you've shown and the perseverance you have in getting that qualification, use that to empower to drive your program.
Lovely. And a couple of submitted questions just now. How do your colleagues react when you talk about trauma-informed practice? Have you experienced any resistance around this? Well, particularly as a surgeon, I guess people will be saying you've sold your trade. Is that what they say?
So it's really interesting, actually. When I first spun up the idea of running an advanced reduction program in a major trauma centre in London, people looked at me like I was insane. I was going to bring on non-trained, non-clinical people onto a ward full of violent miscreants who themselves had quite flowery histories. They thought it'd be anarchy on the streets, and I was bringing some woolly nonsense into a hardcore surgical specialty. And the revelation is actually revelatory. Within days the program started, the patients were calming down, the parents were calming down, the staff were noticing there's less expressed emotion on the ward, and things started to change. And once we let the experts by experience deliver their work, they gained traction with the staff, and they were there in a position to start talking around violence and behaviour. And they started educating our staff about what trauma-informed practice looked like and why the stuff was important. And when the staff started reflecting on their own lives and their own background and how that trauma informed their lifestyles, that was a real key change. And people started thinking more clearly about themselves in that violent space, why they did these jobs, and interacted with individuals, and they changed their practice. So it's all about putting people who've got skills in the right place, letting them show their value. But you have to be accepting to that and have to be open to it. Yes, it's a big change, but I am a frontline cutter. This is what I do, this is what I've been trained to do. I'm not by any means a public health expert, but I have recognised the value of this change in attitude where at the pointy end of what I do. And if it can work where I work, it can work absolutely anywhere.
And of course, you're in a prime spot to actually look at things very differently, aren't you, being a surgeon who sees the sharp end of knife crime. Can I ask you another question? Yes, go on, sorry.
No, I've worked from the A to Z of this. I worked from anywhere from seeing violence in the midwifery unit at London through to going through to the mortuary, and I've been in the courts, I've been in the schools, I've worked all these places in this period of time, and I see how this interacts. And I think that as a cutter, yes, you get a sense of what the injury looks like, but the mental distress you see in individuals who are incarcerated, who are the victims of crime, who've been perpetrated crime, talking to people who've been in prison for 20 years. 30 years from a crime they committed when they were in their teens, brings home to you the impact of what violence looks like.
Thank you. Another question, live question, is serious youth violence equally distributed throughout the UK, or are there any hotspots? I think I could tell you there are hotspots, and there's something about earlier submitted about the Glasgow experiment as well. I don't know whether you can tie this in with that.
So you're going to find more violence when you've got people in tight spaces. You're going to see more violence in metropolitan areas. You're going to see violence when you've got people who are unsupportive, lack of resources. You see violence in areas which tend to be dense populations or areas that are poorer, by and large. Now, the Glasgow model that we're talking about, Violence Reduction Unit in Strathclyde, was based on a model from the States, I think, from the ceasefire model, and it was combining law enforcement with social care to understand violence in Glasgow, which at its time was the most violent place in Europe. And that brought into, rather than policing the place to pieces, they tried to support young men, by and large, Scottish men, to look again at their violence and give them opportunities to develop in terms of more supportive manners. And that was about prescribing family work rather than prison sentences to young people. It was about increasing access to social care and support. It's about understanding violence differently. And Karen McCluskey and Niven are tremendous advocates of that programme, and it's a really lovely piece of work. And then with the navigators in Glasgow producing incredible work to reduce youth violence in that space, and it's almost unheard of in Glasgow. So it's a really lovely piece of work, and it can be expanded upon, but that's only part of the issue. I think with London we have some different challenges. It's a much bigger area. It's got much more diversity in terms of experience, ethnicity, and challenges. But there are bits of that which are franchisable and transferable. It's about having a combined approach. It's about being agile in terms of what we do. It's about empowering local groups to have that autonomy to direct in their own direction.
So, in terms of hotspots, one of the hotspots is Greater Manchester.
Yeah,
and I read somewhere that Greater Manchester isn't part of the national statistics. Why is that? Why do they want to be exclusive of this?
It's not so much that. I think there's an issue about the policing data there wasn't as robust as it could have been, and there were some issues around that. I think that we have good healthcare data there and some brilliant clinicians there who are doing some phenomenal work. Rachel Genders there doing some brilliant work there. I think we have just an issue around data collection from that side of things rather than anything else. I think that we have to be very careful what data we're talking about. We're talking about the ONS data around Sfarville or the crime justice data, or looking at healthcare data. They're all very different pots of information. From what I've got, very strong data of what happens in Manchester in terms of healthcare stuff, and there's a really good data collection and sharing system that's been enacted by the ED clinicians there. What I think is less clear about is the policing data, but the VRU in Manchester are a tremendous group of people who are doing tremendous work to coalesce that expertise and knowledge, and doing tremendous work to understand violence better and make a better plan for the city.
And on the US theme that you were referring to earlier, there's a question about bringing victims and perpetrators together. Do you think that is ethical, it works, and what's your view?
So I've seen some really, so victim and perpetrator is a difficult balance to strike. Like I said to you before, with the example of a young person who stabbed somebody who was chasing with a knife. It's not, you can't be that crystal about victim and perpetrator. There's some really nice work being done in terms of restorative justice, in terms of domestic abuse, and trying to get people to understand what their violence was like and what led them to it. And I think there is utility in bringing together people who have been involved in violence from both sides of that equation to understand what led to them to that circumstances as a part of a therapeutic model. However, it has to be part of a very supportive atmosphere around development to allow you to understand what that's about, to negotiate that experience, and to reflect on it afterwards. So it's not, I think it has great utility and opportunity, but it requires a lot of safeguarding around it, a lot of understanding why it's important.
And what's your approach? Here's another question. What's your approach to the criminal justice system? Should there be better education, better support, a carrot rather than a stick approach from the prosecution?
Right. Okay. So, first of all, if you commit a crime, I want the police to investigate it. I want the person to be caught and punished and given the appropriate sentence. That's absolutely the right thing to do. I want the community to engage with law enforcement to find that individual and to make sure that person is appropriately sanctioned. That's entirely appropriate. I think, however, that what we do is we do not do an awful good job of rehabilitation in prisons. We don't really address mental health needs of individuals in prisons, and we don't provide a good support network for those people who have been imprisoned. I feel that we could do more effective work with individuals rather than locking them in prisons, and I think that we have to think very carefully about what kind of sanction or sentence we give to people who have been convicted of violent offences, whether or not we can support them in different ways outside of the criminal justice, outside of the secure state, and how we look to challenging those behaviours once you've put someone in that space. Because it can't just be lock you away for X number of years and then say off you go to no employment, no education, no future, and see what happens. Because we have to make sure that if we put somebody into that space, we have the opportunity to actually rehabilitate and educate that individual and give them better options to move out of it. And some of the greatest workers I've worked with in this space are ex-offenders who have been rehabilitated and have found their own niche and want to prevent individuals doing that work. I've got a tremendous clinic worker, somebody who's a fantastic clinician and a fantastic advocate for violence reduction, but had difficult circumstances. And I think that what we have to understand is we have as a society to relearn the art of forgiveness. You commit an offence and you're punished for it, that's that sanction dealt with. If you've learned from that and you're a different and better person for it, then we should welcome you back into the community and allow you to share your knowledge and experience in your journey with those who so they don't repeat that experience for themselves.
That's very true. If you say sorry, then yes, if it's genuine. Now we've got another question here from a community nurse, which is about your Violence Reduction Academy. Tell us a little bit more about it. And I suppose somebody like her, how can she get involved with that?
Let me build it first. So we got some funding we've got 280k to get running for the next 3 years. We're going to embed it at Barts Health. We already run a virtual platform on FutureLearn which shares information and practice there, but we'll be moving forward to this is a repository for information first, and then some learning around that, and we'll store our work with HE and those experiences there in due course. But give me a year to get it all in place, and I will send me a number and I'll get you into the game. Lovely,
and of course the BMA will be there for your launch, won't we?
I think you'll be pushing it off. I think probably.
Harvey will get a golden ticket.
I was just going to say, J.S., apropos that, one of the questions I was going to ask you is, how can the BMA help you? And my second question is, have you got any, and there's a question from somebody else here, what's the funding like for youth services?
Right. So we all need advocates, support, and critical friends. So the BMA is the doctors' union, and I think you represent the core of clinicians who are key to understanding and reframing our interaction between healthcare and society. What you do in the community in terms of identifying and addressing individuals' needs and wants is key to guiding how we can do things better. And I think that as individuals are respecting the community, what you do and say matters. So I really need your support, not only to help me spread the message, but also to advocate to me when I'm doing things wrong. So I want as much engagement as possible. Funding is an interesting one. So there is money for violence reduction units, and the government announced £25 million to the VRUs yesterday. £7 million goes to London, and there is within and without the NHS to provide work. But I think it's because we're doing work that is partly social, partly healthcare. It's part of there's an issue around funding cycles for 2 or 3 year programs which require proven evidence, and I'm trying to move away from that short-term funding to try and put in place robust programs which sit at local regional governmental level that provide us with work to deliver those non-clinical activities in the community, and also to allow us to have robust funding for education, training and practice within the NHS that uses our clinical staff in a way to complement what the community are doing to address violence, and the funding will come. But like in most of the NHS, it needs data to evidence it, I suspect.
Thank you very much, Martin. There are plenty of questions. I don't know whether, but we are restricted by time, obviously. So in terms of networks, primary care network, and and also, you know, these new PCNs, and also in terms of public health, just tying up 2 or 3 questions together. How do you rope them in, and what role do they play?
So PCNs are brilliant. I mean, I've had some great support from Michelle Drage and the primary care group in London to offer us support and guidance on how best to shape the offer to primary health physicians and primary care physicians, and that's been a really real boon in order to understand what violence looks like in areas that aren't perhaps so hard pressed for need. It's also identified some great clinicians who work in that space who can give us great ideas around social prescribing. Aaron Hansey, one of my clinical leads, is a GP in North East London. He's done tremendous work in understanding social prescribing better. I think that that where I think the new integrated care systems that are going live this year are going to be a much more powerful lever for change in those sort of local and regional groups, and allow us to integrate what looks in primary, secondary, and tertiary care in a better way. So we can much better understand the data as we share it across that spectrum of the disciplines, and formulate a needs assessment for that community in that area that bears in mind the roles of as individual healthcare providers to provide prevention in a more coherent and way that amplifies the message across the piece. So everybody's saying the same thing at every level of communication, and we have access and knowledge of what services are available in that space. So I think it's an opportunity for us to link and work together better.
And are primary care specialists playing a key facilitative role in your work?
So, as I said, one of my clinical leads is a GP who works in North East London, and he's driving the social prescribing piece of work that sits.
Sorry, public health. Beg your pardon. Public health.
Oh, public health. Absolutely. So we, like I said before, we draw. The public health approach draws expertise from all domains, and public health physicians. We've done some great work with the Public Health England, but with their group this week. Kevin Fenton's a friend and colleague, and we've done some great work in London to understand bias and violence itself. I think that we can't do the hard work without the data and support, and public health clinicians are traditionally regarded as being people who work in the background doing data. Actually, they're very active in that space, have great ideas, and shown great leadership in developing in ideas around that. And the public health people are integral to us understanding the data better, understanding motivation better, and putting in programs better. Because I'm very much an operational guy. My first iteration as a clinician, so we absolutely look towards public health guys and DPA to help us understand better what we're looking at, how to look at proactive support, and how to innovate in that way that allows us to be supportive in earlier stages to provide identifiable and potentially measurable outcome changes. Yeah,
that's great. Thank you. I'll ask you one question, and then Parveen might want to ask another question. But this is from a Justice of Peace, and it is about a window of opportunity. Is there a typical age where you feel interventions become more effective?
I think the earlier you start, the more likely you are to embed understanding and support and appreciation. I like to start with parents of children before they're born, talking about ICON, about not shaking babies, about having a different kind of relationship between parents and their children. And I want to teach skills to young children, mentor younger children, and teach skills to other people. It's much harder to reach and support an individual who's entrenched in behaviour, who's gone into year 8 at school, or is involved in the criminal justice system. But it's much more powerful to speak to that young person's parents when they're a toddler about how Johnny or Jeanette interacts at school, and how they can be better at supporting that child's education and development emotionally. From my perspective, the earlier you start, the earlier it's more effective. But it's about recognising that the methodology and the support you're giving is not about violence in itself. Violence is an output of a failing society, a failing relationship, in terms of how we relate with society. if you get education and support and community right, you get less violence and much happier communities. So a byproduct of a successful community is a less violent, more equal one. So the key is not so much talk about violence as a first up issue, but talk about social cohesion and about support, education and empowerment as our main drivers of support in the early stages, and seeing how that plays out by reducing violence.
Thank you. Parvin, might you have one or two questions?
Yeah, well, no, I was going to leave it all to you, but could I just ask, I think you mentioned earlier on about domestic violence and women coming in with knife crimes. I mean, how do you approach that? Because that's obviously trying to get into the home of a family, and the problem being, of course, the perpetrator is going to be there all the time, and you're going to send the woman back home again. How do you approach that sort of situation?
So one of the things about our violence reduction program at London is that nobody goes home until they're safe. And that, if that means you stay in hospital while we organise a safe environment and we make sure that you've got support around it and you're emotionally right to go home, that might mean the next day or two in hospital, but it's worth it in terms of readmission rates. And I think that we are very sensitive to potential issues, and we I think, to be honest, we learned during lockdown that we actually missed a few individuals who might have been harmed in a domestic scenario who we thought who gave a plausible reason for why they've been injured. We are much more sensitive and attentive towards domestic abuse in all its forms, be it physical, sexual, or emotional, or financial, and we strive to put the right people in the right place. I recognise that when we're dealing with traumatized females, I might not be the right person to do that sort of work. So we make sure that we have individuals on hand to provide that support and ask those difficult questions. More importantly, we are a safety first environment. We provide support and reassurance to the individuals in a place where they have autonomy, they have the ability to speak their mind, and they will not be judged for what's happened to them because they are victims rather than perpetrators in that particular space. And we make it one of our tenets of discharge and planning to make sure that individuals are supported as victims, to make sure they are not at risk of further abuse, be that physical or emotional.
Thank you very much. So now this is the crunch question, if you like. It's a submitted question.
Okay. And
it's about what are your maybe 5 top tips. What has actually worked? So the question says that what has made a demonstrable difference in knife crime rates? So have you got any top tips at all for us, Martin?
Yeah, it's a really good question, actually. And the thing is that you can't tell people what to do. That's the first thing to say. It's not real, it's not practical. What you can do is support people through change and let them recognise where there is an opportunity for development. But it has to be matched by a parallel piece of work in the community. You can't just say go to school without providing support in school. You've got to start early. And you've got to start with the person in front of you and that kid's younger brother and sister as well. You've got to listen to everybody you're talking to, and listen to what they're saying, what they're not saying. It's not just the words, it's the language, it's the body language, it's the emotion. Those things have to be given value to, and you have to engage people in a positive way. You have to give somebody something pragmatic and real to start with, and then create that trusted relationship that allows you to move things forward. People who have been traumatized in the past are quite rightly mistrustful, particularly of authority. And you have to be able to negotiate that space by maintaining your integrity and by supporting the individual to allow them to find their own way. It might be the person you support doesn't want to get a job, wants to live in a council flat with their people doing very little. But if they're not violent, I'll accept that, because they're happy and they're good people, they're looking after their families and they're doing what they can for their people and their children are smiling, and so are they. That's a great outcome for me. You haven't got to work for a university and as a professor to be a success in my mind. You've got to be happy in your life, supporting your family, and proud of who and what you do.
Thank you very much, Martin. Thank you. Well, it falls on me to thank you, and I don't know how to do that actually, because this is a comprehensive, the most comprehensive talk that has absolutely everything in it, from the history right up to what are really good, effective ways of dealing with such a difficult area. And so, on behalf of Parveen and the Board of Science, I want to thank you very much for your delivery and your wide-ranging talk delivered with surgical precision. And of course, you know, we have very many others to thank. Our secretariat, wonderful secretariat, beautiful secretariat, Hope, Anne-Marie, Winifred, and our tech person, Stephen Littlemore, and conference unit. So we're very grateful to all of them. But our thoughts really are with David Gomo, whose life was tragically cut short, and our thoughts are with his family and friends. And there are so many victims like David, but to be cut in their prime, particularly in their youth, which is what this seems to affect most people, you know, really, it's something that we have to change. So thank you very much, Martin. Parveen, I don't know if you wanted to say anything else, but
I think it was actually superb, a very, very comprehensive chat, lots of work to do. And I think, Martin, thank you for giving us hope, and anything we can do to help, please let us know. So thank you very much indeed.
Thank you very much for having me. Just having the audience to speak with you and the chance to share these ideas and have some critical friends around it is more than reward I can expect from you. Thank you very much for having me. Thank you very much for asking those really fantastic questions, and thank you for listening to, you know, what we're trying to do to make our society and community a happier and healthier place. Thank you.
Thank you.
There's a massive virtual applause for you, Martin. So
yeah, that's right.
Thank you very much. Thank you.
Thank you. Bye-bye.
Goodbye, guys.
Bye-bye.